The relationship here. The relationship here, I just want to talk about discomfort and pain for people with their dorsiflexion or plantarflexion, allowing somebody to walk properly, knee pain, all the things we can talk about in terms of IT band that comes down and joins onto the side of the tip here. We've got the small fibular bone here that sits on the outside. Very important junction point here when it comes to the relationship of what's going on in somebody's ankle to what's going on in their IT band or bicep femoris, and then lower back and all about the back. So trying to get some movement, this joint here should have a little bit of movement in it. And you should be able to bend the knee, get hold of it. It's quite hard sometimes, it can be lost in tissue, but we should be able to get hold of it and we should have a little bit of movement. Not much, just a little bit. So to push either way and to work on that is really important to do. Sometimes a release of it where you put your fingers up into behind the knee, you bring the client up and you force your fingers in between, can help stretch those ligaments through there a bit and open that up a bit. So you bring your hand up in here and then take your hand back, you push through, and you sometimes get a bit of a click or a movement. Perfectly safe to do. Obviously, if there's a history of knee issues, then of course you wouldn't. But it just helps to we want to stretch and get this so this is moving here. It's really important to get that movement. Why would you do this? People that are maybe flat-footed, anything to do with the ankle, be that particularly plantar fasciitis, could be shin splints, any kind of toe pain or lack of movement in the foot. From here down, I mean obviously from the pelvis down, you would always work anything to do with the ankle. You start off with a pelvis assessment. You know, you just see what's going on in terms of firing orders and anterior tilt and all the stuff we've been talking about. But now we're just bringing it down, so we're beginning to see here. So if I translate that into Hannah's knee, cupping behind, here's down onto the tuberosity, come out 90 degrees. Here it is, I can get hold of it. If I hold the leg, can I move it a bit? Quite hard because it's very, firm and strong in there. Yeah, I've got a little bit of movement in there. That's all I'm looking for. To do that release, I come up behind the knee, I hold, give that a good stretch, and then come back. Yeah, not much. I don't need much, but a little bit of movement is important to release through here. And you can hold in this position. You might do some massage either side. Quite tender. Working on here. Very important to work on this area. Remember that here you've got the perineals, top of the tibialis anterior. Very important junction area. Very important. So lateral edge of here. Working through here. MEC is great through here. So you could do all that work of engaging, so pushing up into my hand. And then relax. All that stuff that we're good at. If you've got somebody who's got shin splints, let's just drop that in. Shin splints is what? Shin splints is, what is it?
It's extensor digitorum, isn't it, underneath the tibia? Problems in that compartment.
So here?
You're just dropping into this.
Yeah,
this side.
either side?
Yeah.
It can be medial or lateral.
Yeah.
Inflammation of the lining of the bone, where the muscle attaches.
Is it the same as horses where once they've solidified, they're okay, or do they continually keep, like you often get them when you're younger, don't you?
Yeah.
Impact.
Maybe, I don't know. Good question.
With horses, they
yeah.
flare, and
Yeah.
they can stay flared for quite a long time.
Yeah,
but
I think
once
you're
they've
right. I think
solidified, they sort of,
it's muscular.
yeah.
Sorry, it's not muscular. It's the actual lining of the bone where the
Yeah.
muscle attaches that
Yeah.
gets aggravated, inflamed,
Yeah.
and so it's not a muscular. So it is about rest and
Splinting
ice
of
and
the bone.
anti-inflammatories, and it is about waiting for it to get better. But it is, the releasing of the muscle along here. So here's the shin bone, and I'm coming either on the outside or coming on the inside, and I'm sort of pushing through here.
So is it the membrane, the intraocular?
Yes, the membrane is the what's the covering of the bone? It gives a P. Periosteum.
That's what I was
Yeah.
thinking.
Is that right?
That's
Is that right? Periosteum.
So it's not the connective tissue between.
No,
No,
no.
it's the
It's
actual.
inflammation.
the actual-
That's my understanding.
on the back,
Yeah.
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 It's inflammation of the lining of the bone where the muscle attaches.
Okay.
So it's not the tendon. It's not the tendinitis. It's
No.
whatever that. So this move can work quite well. I've done this over the years. Once inflammation's gone down and we're in that place of recovery rather than acute, subacute, so we're into this. But the working of all the dorsiflexion and the plantarflexion and the whole thing that we've been talking about really works. Okay, do you want to just have a go? Have a 5 minutes, just have a little play with that.